Hello, everyone. Today I will discuss with you the impact of momelotinib on transfusion dependence and the quality of life of patients with myelofibrosis. Indeed, anemia is a true problem for our patients with myelofibrosis, present from the diagnosis in about 1/3 of the patients and increasing over time, since more than half of the patients will become anemic after 1 year after the diagnosis, and even more of that with longer follow-up. In addition, anemia is a real prognostic factor for this disease, found to be relevant in all the prognostic scores that are available, from the IPSS to the most recent MIPSS 70 plus version 2.0. So anemia and transfusion dependency are really a burden for our patients. And until now, we didn't have so many options for them. They usually poorly respond to erythropoietin-stimulating agents. We have new drugs which are tested currently, such as luspatercept, for example, or ALK2 inhibitors, and we wait for the results of these drugs that may improve anemia in patients, especially those treated with ruxolitinib. As you know, of course, ruxolitinib is a very efficient drug for the splenomegaly and the symptoms, but usually, at least for the first months of treatment, ruxolitinib induces anemia, which is a non-target effect of this JAK2 inhibitor. And sometimes patients become transfusion dependent after having started ruxolitinib. So now what momelotinib brings us in this landscape. Indeed, momelotinib was tested a long time ago in SIMPLIFY-1 and SIMPLIFY-2 study that allowed to show that this drug was able to give nice responses in terms of splenomegaly and symptoms, but mostly in patients with anemia. Then the phase 3 MOMENTUM study was designed to test momelotinib versus danazol in patients with myelofibrosis who were symptomatic with a high symptom burden and anemic. Only patients with less than 10 grams of hemoglobin could enter in the study. So the MOMENTUM study showed as a primary endpoint that was a response in terms of total symptom score, a very nice and significant improvement compared to danazol, with 23% of patients achieving a response on symptoms versus 3% only in the danazol arm. In addition to this response in terms of symptomatology, we also had a clear improvement in anemia for patients randomized on the momelotinib arm. For example, 31% of patients became transfusion independent after 24 weeks of treatment with momelotinib, compared to 20% only after 24 weeks in the danazol arm. In addition, we saw a very nice increase in the baseline hemoglobin rate from around 8% median to around 9.5 median after only 2 to 4 weeks of treatment on momelotinib, that remained very stable over the course of the disease. In contrast, in the danazol arm, this increase was much less important, up to less than 9 grams, starting at the same level of around 8 grams, and could recover after the patients switched to momelotinib. That was possible to cross over to the momelotinib arm in the patients who didn't respond to danazol. So altogether, these results led to the approval of the drug in patients with myelofibrosis and anemia. So this is very important because, as I mentioned at the beginning of this discussion, anemia is a real problem for our patients. So we can have probably in the future a kind of algorithm of treatment within JAK inhibitors, when first line could be ruxolitinib in most of the patients, and maybe thinking of momelotinib as first line in patients with anemia at baseline, and in particular, those who are already transfusion dependent at diagnosis. That is not a frequent situation, but can occur. And also for patients who develop anemia and become transfusion dependent during a JAK inhibitor treatment, momelotinib would be a nice second line option that provides both symptom improvement and improvement in anemia.